Good morning, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Sunil M. Jain, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, DM in endocrinology, and endocrinologist at Toll Diabetes Hormones Institute Indore. And today, sir is going to discuss on a very important topic, that is understanding HbA1c limitation, when and why to reconsider. Know more about this topic, I would like to invite sir and hand over this session to sir. Sir, stage is yours. You can proceed from here.
Okay, thank you Faraz. Good morning to all. And I am going to talk on HbA1c. So, as we know, this is a very important test prescribed by all the doctors in clinical practice. So, let us understand few areas about HbA1c limitations. We know the importance of HbA1c, but what are the limitations? And that's what I'm going to cover in next 20 to 25 minutes. So, this is a hemoglobin which is bound to glucose, and this became an important tool for monitoring in last 2 to 3 decades. And we know that glucose enters RBCs and has bind a tendency to bind to amino acids on the hemoglobin molecule. This is a non-enzymatic glycation, and glucose basically can bind to any amino acid on hemoglobin protein chains. But its most preferred amino acid is valine, which is present on the beta chain of the normal adult hemoglobin, that is HbA. And once it binds to this valine amino acid on beta chain of normal adult hemoglobin, it forms a compound called beta N1 deoxyfructosyl. And that's what we measure during HbA1c estimation. And through this compound, we try to know how many percentage of hemoglobin is glycosylated in a particular person. And since RBC lifespan is approximately 120 days, few coming, few going, that's how we consider that a major contribution of average glucose is coming from last 3 months. Again, I would like to emphasize that what we are measuring is percentage of glycated hemoglobin versus normal adult hemoglobin. That's what we are doing. And that's how, irrespective of hemoglobin level, you can interpret HbA1c because we are measuring in percentage terms. And in general, 25 to 32 milligram increase in glucose will lead to 1% increase in HbA1c. And this is what is well known, that average HbA1c and what will be the mean plasma glucose. And that's what all physicians follow in clinical practice. But before we understand where are the limitations of this calculation which I am showing here, we have to understand what happens between glucose and hemoglobin. So these are the four chains of normal hemoglobin, alpha and beta. And as I said earlier, hemoglobin beta chain has a valine amino acid. Here, valine at the terminal of beta chain where the glucose will bind. And that's how it get further conformational changes. And all methods for HbA1c measurement are working somewhere here to find out how much percentage of hemoglobin is glycated of the total hemoglobin, and that is what is reported as HbA1c. Now, when we talk of the averages like 6 is equal to 126, there are many assumptions. We assume that the RBC age is consistent among all individuals. That's what the basic calculation will be. It will depend on the RBC survival. We presume that everybody has the mainly HbA. We presume that it is the GLUT1 which is transferring glucose across the erythrocyte membrane is working same in every individual. And in every individual, the binding of glucose to hemoglobin is happening at a constant rate. But this is not true. And that's why there are certain number of patients where HbA1c may not correlate. And that's where we have to reconsider some other methodology, and I will come here in little more detail. We know that erythropoiesis is happening at a constant rate and erythrocyte destruction is happening at a constant rate in a normal human being. And that's where the relationship of RBC lifespan work well. But there are instances when the rate of erythropoiesis can change. Rate of erythrocyte destruction rate can change, and obviously this will significantly affect the HbA1c interpretation because the survival of RBC has changed now. There can be a structural alteration in hemoglobin molecule itself that can lead to change in interpretation of HbA1c. And as we discussed, glucose goes through GLUT1 and then binds to hemoglobin, and there also many factors can come in between. That is called glycation variability. And lastly, there can be some assay interferences. Our blood is containing something else which is interfering in the measurement of HbA1c. So there are so many variables, and I have highlighted 5 points here. Now let me elaborate one by one each point to explain how this plays an important role. So when HbA1c does not correlate, these are the 5 points which I discussed. Altered rate of erythropoiesis. There are many clinical situations. Somebody had a blood loss, had a recent blood transfusion. Someone who is on a erythropoietin therapy, B12 deficiency, folic acid deficiency, aplastic anemia, CKD. All these patients can have an altered rate of erythropoiesis. That means the RBCs coming in the blood may be newer, more in number, and that's how the average, since we are measuring the glycosylated hemoglobin as a percentage of total hemoglobin, this relationship, what we presume, will not exist true. So there will be alterations. Many people can have hemoglobin abnormality itself, and that will again create a big issue in interpretation. Then there are people with wide variety of glycation rate, like in CKD patient with a pH alteration, glycation rate will change, and that's what I'm going to discuss also. And you can see in this slide there are many categories of patients who have CKD, and their HbA1c interpretation can be difficult because CKD works at multiple points. Erythrocyte destruction rate, hemolysis due to any etiology, splenectomy, polycythemia. So many factors which can interfere in the HbA1c interpretation, including a very high triglyceride, which is not an uncommon situation in patients with new onset type 2 diabetes with significant insulin resistance and the so-called the typical diabetic dyslipidemia. So altered rate of erythropoiesis, these are the scenarios where a false increase in HbA1c can happen. Somebody with a vitamin B12 deficiency, folate deficiency, aplastic anemia, RBCs are surviving for longer duration than expected. That means their HB or hemoglobin has a tendency to bind to glucose for a longer duration, and that's why its percentage will increase. While patient on erythropoietin therapy, iron therapy, blood loss, blood transfusion, here now newer RBCs will appear, which have not yet connected with glucose, not yet came in contact with glucose. So obviously, in such people, a false decrease will happen. Let's take an example. Somebody with a significant iron deficiency anemia. His HbA1c is X today. Now this patient receives a iron infusion. Now things will change. A lot of newer RBCs will come into the picture, and this will lead to a rise in hemoglobin. Obviously, these newer RBCs are devoid of any binding yet with the glucose, so they will have a dilutional effect, and that's how the HbA1c will go down. And in addition, iron deficiency will interfere in our diagnosis also from a HbA1c point of view. So these are the factors which will have an altered erythropoiesis effect on HbA1c. So many HB variants, more than 1500 are known here. And we know sickle cell anemia. Suppose somebody is having hemolysis. Certain hemoglobinopathies can cause unexpected alteration in HbA1c because of their difference in the chain in amino acid. And for that, we have to do hemoglobin electrophoresis, like you see hemoglobin Punjab, or in the northeastern part of the country, we have hemoglobin E. So these various hemoglobinopathies can cause either hemolytic anemia or amino acid substitution, altering the process of glycation and may interfere in the methodology also. And we know one of the hemoglobin, that is fetal hemoglobin. And there are many patients who receive certain drugs, which like hydroxyurea, which can cause rise in fetal hemoglobin. In the first 6 months of life, it is the mainly fetal hemoglobin which is present. There can be thalassemia with a higher fetal hemoglobin that will be major. Obviously, in minor, this is a small issue. Hereditary persistence of fetal hemoglobin. And here again, there is amino acid alteration because they have glycine rather than valine in beta chain, and that's how hemoglobin will not have an avidity to bind with the glucose, and that's how it will go falsely on a lower side. So all these hemoglobin variants can be an issue. Next point comes variation in the glycation rate. Iron deficiency state leads to increase in the glycation rate. If somebody has an increase in the glycation rate, means their glucose will bind to hemoglobin more avidly. That means the percentage of the bound to glucose hemoglobin will go higher, and that's how HbA1c can go higher. And iron deficiency anemia, if it is significant, can create a discrepancy in the diagnosis of diabetes if we are going to follow only HbA1c criteria to diagnose. Vitamin C and vitamin E. Higher doses, I'm not talking of 300 or 500 mg, but 2 gram kind of doses can decrease the glycation rate. And that's how the HbA1c can be falsely low. Chronic low dose aspirin, but this was a minor effect. While a higher dose of aspirin, which is used by like rheumatologists in a dose 1.5 to 2 gram, can increase it by acetylation process. And one more very important physiological parameter. There are patients who are high glycators. There are patients who are low glycators. What I mean to say, there are subset of human beings whose hemoglobin will bind to glucose more avidly. We call them high glycators. Another subset of human beings whose hemoglobin does not have that much affinity, which will have due to multiple factors, including pH, GLUT1, etc., which I talked about. These are called low glycators. And this concept is called glycation gap. Means what you were expecting to have a HbA1c versus what was actually came. That is glycation gap. That is an individual variation. Obviously, the patients who are high glycators, that means their hemoglobin has a higher avidity to bind with glucose. Their HbA1c will be higher while their glucose doesn't go that high. These are called high glycators. Another subset where the hemoglobin has a low affinity to bind to the glucose. Obviously, their HbA1c won't reach that high. Though their glucose is reaching that high, they are low glycators. And high glycator versus normal expectation, this is called glycation gap. And same for low glycators. And such kind of many patients do exist in our clinical practice. So there are many reasons because of which the binding of hemoglobin with glucose can have a different alteration rate. One is a physiological variation, which is called high glycator. When we talk of scenarios where a HbA1c can be falsely higher. So individuals who are high glycators. And very important thing in India, iron deficiency is a Flow rate, very common scenario. It will also can lead to false increase in HbA1c, higher dose of aspirin, and aging also can have some effect on the rate of glycation. Out of this box, the first 2 points are clinically very important for physicians. False decrease, low glycator. That's a physiological variation which I discussed. Other areas are less important, but they can happen. Coming to the fourth point, that is erythrocyte destruction rate. Since we are considering a RBC lifespan of 120 days, and that's how calculating the percentage of bound hemoglobin to glucose, and that's how we are giving a prediction that this will be estimated average glucose. Now, any clinical scenario where erythrocyte or RBC is destroyed at a faster rate, obviously the hemoglobin will not have an opportunity to bind to the glucose, will disappear, and that's how this relationship of hemoglobin to glucose 120 days will be spoiled. Patients who have undergone splenectomy and patients who have polycythemia, what can happen? In these patients, polycythemia obviously will be a rare condition, so let us focus on splenectomy. Somebody underwent a splenectomy. We know that the RBCs are finally cleared through spleen. So what will happen? These RBCs now will survive longer and they will have a more opportunity to remain in touch with glucose, and that's how a false rise in HbA1c can happen. But more important is a false decrease. And here there are many conditions which can cause a false decrease in HbA1c. Those hemoglobinopathies which cause hemolytic anemia. And there are such many scenarios. G6PD deficiency, people have a subtle hemolysis going on. Patients who have autoimmune disorders with autoimmune hemolytic anemia. Many patients are receiving drugs like antiretroviral drugs. Leprosy patients are receiving Dapsone. Now we know that these are the drugs which can cause subtle hemolysis. And, and because of this ongoing hemolysis, their HbA1c will not rise. So their glucose may be quite high, but their HbA1c is coming good. So don't be happy by looking at HbA1c. Their diabetes is in fact grossly uncontrolled. Patients who have hypersplenism, patients who have CKD beyond a creatinine of 2.5 to 3, the RBC lifespan can be shortened. So there are so many clinical scenarios where HbA1c here will be falsely decreased. So if we trust on HbA1c in this scenario and patient is happy that my diabetes is controlled, it's not correct. Their glucose levels are high. So we have to keep all these factors in mind. And one another area, what are certain substances in a assay which can interfere in HbA1c? Any patient who has a triglyceride levels more than 700, 800, that means the sample will be lipemic. And such a high triglyceride interferes in the HbA1c and can cause decrease, while quite a high bilirubin level can cause an increase. Now, out of these two scenarios, the hypertriglyceridemia is very common. You come across many patients in practice who have triglyceride maybe 1000, 1100. Their glucose may be quite high, but you may see in such patient there that HbA1c is not correlating to their glucose. And this may happen because they have a very high triglyceride. Once you lower the triglyceride and repeat the HbA1c, then you will come to know the difference. So there are many assay interferences also. So what I wanted to convey here so far is HbA1c is a very important clinical test. It's a test which gives us an idea about an average glucose of around last 3 months. Out of the last 3 months, the major contribution is coming from last 6 weeks. that is contributing to around 60 to 70% is coming from 4 to 6 weeks. But there are clinical settings and scenarios where HbA1c RBC relationship doesn't work absolutely fine. And it is possible that in those settings, HbA1c may have unreliability, and there we have to reconsider other methodology. So, how to clinically approach? First, think of, does the patient has anemia? If somebody has anemia, it can be hemolytic, it can be iron deficiency. Somebody has a hemolytic anemia. If required, we should do hemoglobin electrophoresis. Look at the kidney function. Are patient receiving certain drugs which may be responsible for a HbA1c alteration? Blood transfusion. Any clue to hypersplenism, including the COL patients? Splenectomy. Normal physiological variation, very high triglyceride level, and these are not uncommon clinical practice scenario. Any patient is having anemia, it may be autoimmune, it may be hemoglobinopathies, that's what I discussed with you, hypersplenism, G6PD deficiency, drugs causing hemolysis, erythropoietin therapy in CKD. Now all people have fresher RBCs coming. IRBCs are either destroyed faster. Obviously, the HbA1c will not be correct, it will be lower than expected. Iron deficiency, B12 deficiency, erythropoietin deficiency, everywhere in this scenario, RBCs are surviving longer and they are keep connecting with glucose, their hemoglobin, and that's why anemia will have a false HbA1c high. So, HbA1c is a good test for routine clinical practice, but there are certain limitations which I try to highlight. And whenever we come across such patients who may have one of these limiting factors, we must make it sure to reconsider HbA1c as a diagnostic and therapeutic monitoring tool in patients with diabetes. So, my concluding remarks will be HbA1c interpretation should be based on complete medical history. That's what I elaborated. Whenever there is an unexpected result between HbA1c and what patient is bringing to you as a glucose readings, you should keep a possibility that one of the five glucose HbA1c disconnect reason may be present in this patient. Try to identify the factor. If it is treatable, treat it independently, that is fine. But in such scenario, consider alternative method for glucose monitoring which does not influence by HbA1c. If no option available, we are not depending on HbA1c just now, we have CGM also. We can involve more patients into SMPG, and that's how still we can manage our patients' diabetes very well. So, friends, I want to convey here that HbA1c is a good test, but don't look at blindly on it. Look at the other clinical parameters also before interpreting HbA1c, and when these scenarios are present, think of alternative methodologies to monitor patients' glucose. So, with this, I will end up here. Thank you very much. If there are any questions, I'll be happy to answer.
Thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, like I can see, sir, some of the feedback. One is from Dr. Anjali. She has written, very important topic. Thanks for discussion. And one
Thank
more
you.
feedback I can see from Dr. Subramaniam. He is writing that very practical, well presented. There are two feedback taken from the two doctors, sir. I hope, sir, you have done justice to this topic, sir. I need to, as I can see, sir, there is no more questions, sir. With all your permission, shall we conclude this session?
Sure, sure. Thank you. Thank you.
Yeah, I hope, sir, we are able to justify this topic. Then only people are not asking the questions, sir. And thank you so much for your valuable time. You have presented really well. And we would like to see you in future also with different topics, sir. Till then, take care of
Okay.
yourself.
Okay.
Sir,
All
one
right.
question, sir. I just saw one question, sir.
Yeah. Yeah.
And what about, sir, HbA1c in CKD patient? Just we have
Yeah,
received from Dr.
so
Vato.
that's what I was telling earlier. In CKD patient, there are so many factors which can influence HbA1c, including RBC survival, erythropoietin therapy, pH, glut issues. So generally, what I follow in practice, once the patient's eGFR is less than 30, creat is more than 2.5. I don't use HbA1c as a tool for monitoring glucose. Now I depend mainly on SMPG because many factors influence HbA1c in CKD. Somebody with up to GFR of 45, you can still use it, but now as the GFR is going down, the utility of HbA1c is decreasing.
Thank you so much, sir, for sharing your insight on this question. I hope Vato has received his answer. And sir, with this, we are on the conclusion, sir. And thank you so much, sir, for your valuable time once again. Take care of yourself, sir. We would like to see you in future also. And it was really nice to have you, sir. Thank you so
All
much.
right. Thank you. Thank you. Goodbye. Thank you.
Bye, sir.
Bye.